Well, thank you very much for your kind introduction, Cyril, and it's a great pleasure to be in Antalya. I'd like to thank the organisers, particularly my good friend, Professor Durson, for inviting me. So for the next 20 minutes, I'm going to talk about the treatment of depressive symptoms in schizophrenia. Let me start just by showing my declaration of interests. Now, depressive symptoms are very common in schizophrenia. They're really the norm rather than the exception. But they tend to be under-recognised and under-treated. And there are several reasons for this. Their nosological status is confusing. There's difficulty in recognition. And I also think there's historical issues at play here. We've already heard about Kreplin's dichotomy and how he divided dementia praecox from affective psychosis. Dementia praecox having a worse prognosis, a continuous course, affective psychosis, a better outcome and an episodic course. But very much in this differentiation, by using affective symptoms to differentiate, it tended to put people off looking for depressive symptoms in schizophrenia. Despite this, historically, depression has been recognised. Mayer Gross talked about despair being a secondary response to a psychotic episode, and Bloiler also emphasised the role of depression in schizophrenia. If we turn to look at the epidemiology, estimates of the lifetime prevalence of depression in schizophrenia vary widely. Depends on the patient's setting. Are we looking at inpatient samples, outpatient samples? What period are we looking at? Are we looking at point prevalence, a 1-year prevalence, a lifetime prevalence? And most importantly, are we defining depression as an isolated symptom of low mood or a syndrome such as DSM-5 major depression? If you look at syndromal depression, estimates of lifetime prevalence range from 6% to 75%, but most commonly a figure of 25% is quoted. And this is twice the lifetime risk of depression in the general population. Clearly, if we look at an isolated symptom of depression, the prevalence will be higher. And in the Australian Psychosis Survey, 80% of people with schizophrenia reported suffering from low mood at one point. And if you looked at the last 12 months, over half of patients reported low mood. A useful clinical standpoint when you see a patient is firstly, and you're thinking, do they have depression, is to think, can I exclude any medical disorders that may masquerade as depression? So, for example, anemia, infection, neurological disorders, hypothyroidism can present with tiredness, excess sleep, poor concentration that may mimic depression. Certain medications, such as steroids, beta blockers, and hypnotics, can present with apparent depressive symptoms. People who misuse alcohol and smoke cannabis regularly, again, can present with depressive symptoms. And stimulant withdrawal can present with a depressive crash. If you look at drugs that are acceptable in our society, for example, caffeine and nicotine, people who suddenly stop using those drugs can present with depressive features. And certainly in the UK now, many of our inpatient wards, in fact all our inpatient wards, ban smoking, and many of them ban caffeinated drinks. And so patients who are admitted and have been drinking a lot of coffee and tea and smoking a lot, in their first few days on the wards, this can mimic a depressive syndrome. The previous speaker talked in great depth about the importance of negative symptoms, and it's important to differentiate these from depression. We have two main domains of negative symptoms. We have decreased emotional expression, and we have avolition. And these can clearly mimic depressive symptoms. In terms of distinguishing features, clearly if a patient describes sorrow, low mood, they're tearful, that suggests depression. And if they simply talk about lacking interest, that is more consistent with negative symptoms. But the reality is that many of our patients do not have the verbal skills to describe their mood in great detail, and so it can be very difficult to differentiate. So some clinical clues that can help us, based on the fact that direct questioning of mood often has limited value, is to observe the patient's facial expression. I think it's often then useful to ask them about their level of interest. A patient with depression will often say, I'm no longer interested in seeing my friends. The football team I used to follow, I don't watch the game anymore. When the phone rings, I don't want to answer it. I don't want to see my friends. A person with negative symptoms is perhaps more likely to say, I still follow the football team, but in a very robotic way. There's no passion there. It's also, secondly, helpful to ask about cognitions. When patients talk about feeling guilty, hopeless about the future, worthless, and when they talk about suicidal thoughts, these are all consistent with a depressive syndrome. In the literature, we sometimes read about antipsychotic-induced dysphoria. And you can understand where this concept came from. We know that dopamine is involved in reward pathways. And so at one level, it makes sense that if you block dopamine receptors, we may get anhedonia, and we may even cause depression. And certainly there are anecdotal links between using antipsychotics and patients becoming depressed. But if you look at high quality research, it does not support a link between antipsychotics and the causation of depression. To the opposite, if you look at prospective studies of psychotic patients, they often have low mood before they start antipsychotic treatment. And as you treat the psychosis with an antipsychotic, not only do the psychotic symptoms diminish, but so do the depressive symptoms. If you look at patients on antipsychotics and patients who are not on antipsychotics, there is no higher rate of depression in the patients on the antipsychotics. And when you look at schizophrenic patients with depression and those without, there is no link to the antipsychotic dose or the plasma level. Now, although antipsychotics, I do not believe directly cause depression, they can cause extrapyramidal symptoms, and these can mimic depressive syndromes. So firstly, let's consider akinesia. And akinesia is one part of the classic Parkinsonian triad of akinesia, tremor, worse at rest, and rigidity. Now, Parkinsonism can be very obvious. We've all seen the classical patients who have a stooped posture, their arms are held rigidly at the side, and they have a festering gait. Often their facial expression is typical. They dribble saliva, their forehead is smooth, they have staring eye contact, there's no blinking, they often have a greasy skin. And when you have a patient like that, it's quite obvious they are Parkinsonian and not depressed. But Parkinsonism can exist in far more subtle forms, and then it can be very difficult to differentiate from depression. Just small muscle groups may be involved, it may just be the facial muscles involved, there's a lack of expression. Let's also now turn just show you this diagram. So this is a classic patient with Parkinsonism, the stooped posture, the arms flexed at the elbow, the lack of arm swing, and the shuffling gait. Akathisia can sometimes mimic an agitated depression. Seris described akathisia almost as if the starter motor of a car wouldn't turn off. And again, when akathisia is very marked, it is very obvious. The patient may stand and sit repeatedly. They may pace on the spot. They may rock back and forth. But again, it can be much more subtle. Akathisia has a dysphoric component, very unpleasant feeling of unease and sometimes depression. But again, patients often find it very difficult to verbalize that. I'll just say something about schizoaffective disorder, which I think is a confusing and difficult term. This was first used in the 1930s to describe patients who had features of schizophrenia, but also features of an affective illness. In DSM-3, schizoaffective disorder was the only syndrome with no operational criteria. And I think that in itself says something about the difficulty of conceptualizing it. DSM-4 did operationally define schizoaffective disorder, but the reliability and the validity of this diagnosis is very poor. And in clinical practice, many psychiatrists give patients a diagnosis of schizoaffective disorder, and they don't fulfill the criteria for that. It's difficult to know why that is. Some people have speculated that schizoaffective disorder may be less stigmatizing than telling someone they have schizophrenia. DSM-5 has retained the diagnosis of schizoaffective disorder and has been somewhat more restrictive in the criteria that are adopted. Some of the problems with schizoaffective disorder are: does it mean a subtype of schizophrenia? Does it mean a subtype of affective disorder? Is it a third distinct entity? Is it simply a point or a continuum between schizophrenia and affective disorder? Or is it an erroneous concept altogether? I think it's best to discount the term. The key point is that depression is often a core feature of schizophrenia. And depression can really occur in three main ways. Some people have depressive symptoms as part of their prodrome. And this is seen actually in over 50% of patients before they present with clear psychotic symptoms in the days or weeks before a psychotic relapse. If you examine them carefully, they will have depressive symptoms. And maybe some of these patients have developed depression because of stress, and then the stress has built up and then triggered a psychotic episode. So that's depression as part of the prodrome. Another pattern of depression is where depression appears at the same time as the psychotic symptoms, and its longitudinal course tends to mimic the psychotic symptoms. And as I'll show you, as you treat the psychotic symptoms with an antipsychotic drug, the depressive symptoms diminish in parallel. And then there's this rather confusing term, post-psychotic depression. Now, in the 1970s, this term was used to describe people who, as soon as their psychotic episode stopped, immediately the psychosis went, they presented with depression. And it was often said in psychodynamic it's the onset of depressive symptoms at any time when psychosis is really very level. So it's depression appearing when there are not prominent psychotic symptoms. And the patient may not have had psychotic symptoms for many months. It does not just have to appear when the psychosis resolves. I mentioned a study to you that was done in Birmingham in 1990, and Max Birchwood took 105 patients with schizophrenia, and he assessed them within a few days of them being admitted to his ward with a psychotic relapse. He assessed them again when they were discharged, and he assessed them on several occasions over the next year, and he mapped out their positive and negative symptoms, their depressive symptoms, and their treatment with antipsychotic drugs. And what he showed that 70% of patients, when they were admitted with an acute psychotic episode, had clear depressive symptoms. And those depressive symptoms resolved in parallel with the psychosis. A third of patients, at some later date, when they were not psychotic, developed depressive symptoms. And the mean time between the psychosis resolving and this post-psychotic depression appearing was 8 months. So it is not a depression that appears as soon as the psychosis goes. There was no support at all that antipsychotics were causing depression in this study. So in summary, his research showed that depression could follow the same course as positive symptoms, or depression could occur de novo when patients were not psychotic, and there was no support for this sudden burst of depression as soon as your psychosis resolved. Bloiler originally believed that depressive symptoms were a good prognostic indicator. And this idea persisted for many decades, but it actually is a myth. And the evidence is actually to the contrary. If you have depressive symptoms with schizophrenia, it is a bad prognostic factor. We know that depressive symptoms contribute to suffering of the patient and the family. We know that depression impairs psychosocial performance at work, in relationships, and your involvement in hobbies and interests. Depressive symptoms predict a longer illness duration, and they're associated with more frequent relapses. And most importantly, depressive symptoms are a risk factor for death by suicide in schizophrenia. The suicide is 13 times more likely in people with schizophrenia than in the general population. And unfortunately, 1 in 10 people with schizophrenia will kill themselves. And these patients are far more likely to have had depressive symptoms before they killed themselves. And suicide in schizophrenia is particularly associated with hopelessness. Depression is also associated with non-fatal self-harm in schizophrenia. So let's now move on to some practical points about how we treat depression when it coexists with schizophrenia. A careful assessment is obviously important. It's important that we offer support to our patients. If the patient is known to have schizophrenia and presents with depression but is not psychotic, watch the patient very carefully, because I've already said to you the depression can be a prodromal feature, and many of these patients will develop psychotic symptoms in the coming weeks. Remember what I said about differential diagnosis, and treat any medical conditions that coexist. Particularly look for substance misuse. Consider whether extrapyramidal symptoms could be mimicking the depression or adding to the depressive symptoms. So if akinesia, a feature of Parkinsonism, is present, consider reducing the antipsychotic dose. You may consider switching the antipsychotic or introducing an anticholinergic. Introducing an anticholinergic can be very helpful because it leads to a very rapid improvement in Parkinsonian symptoms. Dose reduction, antipsychotic switching, and anticholinergics can help akathisia. Akathisia can also be helped by prescribing a beta blocker. But clearly, that is partially contraindicated if the patient has asthma. Benzodiazepines can be very useful in relieving akathisia, and benzodiazepines remain a very useful class of drug, as long as we prescribe them carefully and don't continue the prescription too long. The further treatment of depressive symptoms is partly dictated by the stage of the illness. If the depressive symptoms are thought to be part of a prodrome, it may well suggest that you put up the dose of the antipsychotic medication. If the depressive symptoms appear as part of an acute psychotic episode, the literature would suggest that simply treating with an antipsychotic will lead to their resolution. Antidepressants can be helpful, as I'll show you, but they're perhaps most helpful or most indicated when a patient presents with depressive symptoms in the absence of florid psychotic symptoms. Now, the actual evidence base for using antidepressants is not as strong as many people think. There was a Cochrane review that looked at all randomized controls of antidepressants versus placebo in people with schizophrenia and depression. There were only 11 studies that could be analysed. They were all very small. Every one of them had less than 30 patients in each group. And the quality of reporting varied a great deal. Saying that...
Peter, I'm sorry, we are a little bit out of time.
We need to hurry up?
Yes.
Yeah, we're going to hurry up. We're going to go quickly. Okay, so the key point is there is some evidence that antidepressants do work. The second thing is, if antidepressants have worked in depression, it is helpful to leave the patient on the antidepressant. There's some evidence that prevents relapse. Clozapine, there is evidence that clozapine has a more specific antidepressant effect than any other antipsychotic, but the data is limited to 3 randomized controlled trials. But again, further evidence that clozapine is a very unique drug. A range of psychological interventions can help depression: family support, psychoeducation, supportive psychotherapy. But a Cochrane review suggested that CBT was the most effective psychological technique. This is my final slide, so let's just summarize the main points we've looked at. Depression is very common in schizophrenia. Unfortunately, it is often missed by clinicians and it is not treated. And that's a big drawback because depression contributes to poorer outcomes. And in particular, it is a very strong predictor of self-harm and suicide. It is helpful, I think, to base your treatment on some ideas about differential diagnosis. Exclude medical illnesses that may masquerade as depression. Treat substance misuse, treat substance withdrawal, and treat extrapyramidal symptoms. Try and differentiate depressive symptoms from negative symptoms. When depression is part of a psychotic episode, your first-line treatment is to treat the whole syndrome with an antipsychotic. When depression occurs without florid symptoms, use an antidepressant, and CBT and psychological support remain very important. I'd like to thank you for your attention.